Chapter 9 starts the discussion on airway management. We're going to talk about physiology, the airway, pathophysiology. We'll discuss opening that airway, some options we have there, and then maintaining the airway, making sure that it's going to stay patent, and how we're going to keep it open. So physiology, the anatomy of the airway. The airway is divided into the upper and lower portion. The upper airway begins in the mouth of the nose. Air comes in. The pharynx lies posterior and inferior to the mouth and nose. The oropharynx is the upper part. The nasopharynx is the middle portion, and the laryngopharynx is the lower portion. And that larynx is a landmark. We look for the larynx is that boundary between the upper and lower airway. So as you can see on this picture, that nasopharynx, the nasal cavity, the oropharynx, that oral cavity, the laryngopharynx, it's coming down a little bit farther, and then where we've got the vocal cords and so on. This would all be consisting of what we would define as the upper airway. The lower airway, that trachea, lies below the larynx. The main stem bronchi branch off from that. They become smaller, come into bronchioles. The pulmonary capillaries surround those alveoli, and those alveoli are responsible for oxygen and carbon dioxide exchange. So here we go, a nice picture of that lower airway with the larynx coming down, the trachea, and then the bronchi stemming off. There's your alveolar sacs, kind of look like little cauliflowers. Want to make sure that we keep those perfusing. Pediatric airway, we did discuss this earlier in anatomy and physiology, to keep in mind that the mouth and the nose are smaller, they're more easily obstructed. The tongue is proportionately larger in pediatric patients. Newborns, infants, remember they are nose breathers. We got to make sure that we keep that in those nasal passages open, suction if needed. The trachea, softer, more flexible. It is easily obstructed because of that by swelling and from any foreign objects that could get in the way there, whether it's food or objects they put in their mouth. The chest wall is smaller and the breathing's more dependent on their diaphragm. So you have seen this picture before, the adult versus the child. You can actually see in proportion how different those structures look. Notice that the child's chin is angled forward, so we've got a little challenge there, and we can discuss managing that and kind of getting that a little more neutral midline shortly here. So pathophysiology, variety of obstructions interfere with airflow. Okay, so about foreign bodies, of course, food and toys, blood, vomit, loss of muscle tone. So if we have an unresponsive patient, you can't always guarantee that they are going to be able to manage their airway adequately. Obstructions can be acute, meaning short-term or chronic, and we need to make sure that we're constantly evaluating and monitoring for that patency or that open airway consistently with our patients. So anaphylaxis, if we've got allergic reaction on board, it can cause those airway tissues to swell, and we can lose our airways with our patients quite quickly. Burns, trauma, any of those type of infections can also cause swelling of the tissues. It should say tissues, not issues, in and around the glottic opening. So strep, tonsillitis, epiglottitis, any of those infections can cause our airway to swell. So when we talk about sounds, lung sounds, it's kind of an acquired talent to listen to lung sounds and be able to identify them. It takes some time, but these four main ones seem to be pretty common, a lot more defined. So stridor is that high-pitched whistling sound. If we hear that with patients, it's usually an upper airway. It is an upper airway challenge, severely narrowed airway passage in the upper airway. Hoarseness, raspy change in the voice, swelling. So smoke inhalation is pretty common with that hoarseness, that raspy change. Snoring, similar to snoring during sleep. So diminished muscle tone, it's the tongue getting into the way. If it's in an unresponsive patient, that is not good. That is an alarming sound. And then gurgling. So anything gurgling in the upper airway, we've got vomit, blood, secretion, something in there. We're going to need to suction and get that taken care of. So the first thing we're going to do with airway management is we're going to decide, is it open? Is it patent or patent, whichever way you say that? And the next thing would be, is it going to stay open? Okay. Well, if your patient is talking to you and responding, we know that we've got an open airway or they wouldn't be able to talk. Stridor, if we're hearing that high-pitched sound, it could be an ominous sign of a blockage in the upper airway. So as a whole, breathing should really not have much noise, okay? We don't walk around listening to people breathe. People don't breathe like that. So any noises that are associated with it, we need to look into and see what's going on. So gurgling, any gasping for air, crowing, the wheezy sound like your asthmatics, allergic reaction, and then snoring. So any sound like that, we need to look into this and see what's going on. Some patients are going to use their body position to keep their airway open. Okay, so whether they're tripoding, which they're leaning forward, trying to get air in, and we always need to make sure that airway is one of the first and foremost things we're going to do in patient assessment, okay, to stop and fix immediately. If we don't have a patent airway, if our patients aren't getting ventilation, we're going to have no patient. So we need to make sure that we're always monitoring that airway. So once we get that airway open, is it going to stay open, or do we need to interfere with that with an airway? It's not just a moment in time. It's not a one and done thing, especially when your patients are critical. You need to make sure that we are constantly reassessing that airway and that airway is being maintained. So if an airway is partially obstructed, you should be thinking, okay, how long is it going to be before it's completely blocked? So in the event of an allergic reaction, for example, if your patient's having a hard time talking to you, you should probably be ready for more advanced airway measures to make sure we can keep that airway open. Altered mental status is going to be a consideration also to make sure that we are assessing airway, and in the event that something goes wrong, we've got our tools ready to go to make sure that we're keeping that airway secure. So inadequate airway, when we say we've got an inadequate airway, no signs of breathing or air movement. No air is felt at the nose or mouth. They're not speaking. They can't talk. They have a hoarse or raspy voice, so smoke inhalation, or if they're involved in a fire. If we aren't seeing chest movement, we should see equal, even chest rise, uneven chest movement. If adults are doing belly breathing, those accessory muscles, were just signs that the airway is not adequate. Any abnormal noises, as we just discussed, is a sign. In children, those retractions, so if it's like it looks like they're sucking in above the clavicles and between and below the ribs, that is not a good sign. And in infants and kids, if they're nasal flaring, if they're trying to flare those nostrils to get air in, it is signs that the airway is not adequate. So a couple of different ways to open the airway. The first and foremost thing you need to do is make sure the airway is open. To open and maintain that, there's a couple of different ways we can do that. If we have a suspected spinal trauma of any sort, we're going to need to protect the head and neck with what's called C-spine, and we'll discuss that later on. But airway always has priority over spinal protection, but we are going to provide manual stabilization, okay, if we can't do a full spinal immobilization. So in unconscious patients, look at your mechanism of injury, okay? Look if the head is involved, if the neck is involved, if the family says they fell, they dove, they hit their head, things like that, we're going to need to take spinal precautions. Some patients do have opened but threatened airways. Help your patients into a comfortable position. Nobody probably wants to be laid down. I'm guessing they want to sit straight up or sit semi-Fowlers. Unconscious patients, get that head elevated just a little bit in that sniffing position like you're sniffing the flowers. That helps. That position helps with breathing. The head is just kind of moved just a little bit back, not very far. In pediatric patients, remember I mentioned that the chin is going forward. If you put some padding right behind the shoulders, that should pull that head up into the neutral midline position. So there's your sniffing position, all right? So just keeps that open, that the trachea nice and open, and only when we don't have suspected spinal injury. Okay, if we have spinal injury, we cannot do that. We need to do something else. So the two maneuvers we're going to look at is the head tilt chin lift, which you had in CPR, and you probably had the jaw thrust as well. The head tilt chin lift maneuver, you're going to place one head on the forehead and your fingertips on the center of the lower jaw and tip the head forward by applying pressure to the forehead. This one you can do when you don't have spinal injury suspected. All right, so there's your head tilt chin lift maneuver. The jaw thrust maneuver is when we have an unconscious patient with a possible spinal injury, or any patient with a suspected spinal injury. We need to keep head, neck, and spine aligned. Okay, kneel at the top of the head. You're going to place one hand on each side of the lower jaw at the angles of that jaw, just below your ears, just where it bends there. And you're going to push it forward with your index finger. Okay, we do not tilt the head there. So you're seeing where she's gripping the jaw there and going slightly forward. Obstructed airways. If an open airway is obstructed, consider the possibility there's something in there we've got to get out. So choking is severe or non-severe. If it's severe, the trachea is fully blocked and there is no air moving. Okay. In non-severe, the trachea is partially blocked, but they're coughing and coughing and coughing, maybe giving you the choking sign. So conscious severely choking, if they're conscious, you're going to stand behind them and give them the Heimlich maneuver, putting that fist over the navel and pressing that abdomen with quick, forceful thrusts and repeating until the obstruction clears or the patient becomes unconscious. Conscious severely choking infants, we're going to do the back slaps and chest thrusts like you learned in CPR, laying the infant along that forearm in prone position, so face down with the head lower than the body, let gravity help you. Supporting the head with your hand, giving it 5 forceful back slaps, and then cradling with the forearm and turning him over and delivering 5 rapid chest thrusts. Okay, and we're going to alternate until the obstruction clears or the infant becomes unresponsive. If any patient becomes unresponsive, you're going to start CPR. All right, so when we talk about airway adjuncts, if we've got to put an adjunct in to maintain and keep our airway open once we've opened it, the two common basic airway adjuncts are the oropharyngeal airway, or OPA, or the nasal pharyngeal airway, NPA. The main function of these two devices is to keep that tongue from blocking the airway when the muscle tones diminish. So unresponsive, altered mental status person, we're going to consider putting a basic airway in to protect his airway. The oral airway, or OPA, only used on patients not having a gag reflex. If they have a gag reflex, so that thing going on when you put it in, you cannot use that airway. Okay. If they can't tolerate that, then you're going to use a nasal airway or a nasal pharyngeal airway, NPA. So when starting the airway, you got to be careful not to push the patient's tongue back into the pharynx because you're defeating the purpose of putting one in. Always, always, always have suction ready when you are managing airway. It is a must. If you're doing the oral airway and the patient begins to gag, it is a no-go. You're going to have to switch to a nasal. If the patient becomes conscious, you can remove the airway and make sure you have gloves, proper PPE. Make sure you should probably consider goggles as well. Anytime body fluids are involved, you should be masking, goggles, and gloves. So an oral airway, or an oral pharyngeal airway, OPA, is a curved plastic device. It's got a flange that rests against the patient's lips. That's right on the teeth. It moves that tongue forward as it curves back, right? So we've got several different sizes, and there they are right there. And you'll be doing these during skills on mannequins, not each other. So determining the size, how we measure these oral airways, is we go from the corner of the mouth to the tip of the earlobe on the same side. Corner of the mouth to the tip of the earlobe. So there she is measuring corner of the mouth to the tip of the earlobe. Okay, you're going to use a cross finger. It's almost like snapping your fingers technique to open. Push your thumb on the lower lip and your index or middle finger up. And it's like you're almost snapping your fingers. And you're going to position that airway device with that tip, curved tip pointing toward the roof of the mouth. I know it doesn't seem like we want it to sit there, and it won't sit there. But to start it, we don't want to push that tongue into the pharynx. So we're going to start it with the corner. There they are doing that cross fingers technique. And they're going to put the curve up toward the roof of the mouth. And then we're going to rotate it 180 degrees so the tip is down. And that flange, that little tip of the top there of that airway is against the teeth. An NPA, if their patient has a gag reflex, they're seizing, their teeth are clenched. We've got facial injuries that we can't use the oral, anything orally. We're going to try the nasal pharyngeal or the nasal airway. If your patient has a possible skull fracture, a severe nosebleed, that's what epistaxis is, any nasal trauma, you might not be able to use this airway. So nasal airways are very flexible. We use a water-based solvent to lube them up. And how we measure the nasals is from the nostril to the tip of the earlobe, okay? Nostril to the tip of the earlobe. There's a bevel on it, or like a slice, a bevel on that airway. That should go toward the base of the nose, or the septum, the middle of the nose. So there they are measuring it, tip of the nose to the tip of the ear. There's your water-based lubricant. Do not touch that with your hands. Make sure you're just using it just like they're doing, opening that packet and doing that. Remember, your gloves have infection of we don't know what on it, so we don't want to be putting that into patients' orifices. Pushing that tip of the nose upward and taking that slice or that beveled side toward the septum wall, the septal wall, and then it just inserts straight through and right behind the tongue. Okay, so those are our two basic airways. If we need to use in a more invasive measure, we have supraglottic airways. EMT basics are allowed to do. So if other basic measures have failed, we're going to need to look into a more advanced airway. So pre-oxygenating the patient is a big one. So even if you're going to do an advanced airway, get the basic airway in place and start ventilating your patient. You're going to need to get your equipment ready to go before doing any techniques. Actually, you should be making sure everything's ready to go. All your tools that you need are there. So I've got a couple of here on the slide. The iGel is the latest and greatest. The King LT is in the middle there, and the Combi Tube is on the right. And you will be learning all three of these during skills. These supraglottic airways are also called blind insertion airways, and the reason they're called that is because you are not visualizing the vocal cords to have a true intubation, okay? True intubations, paramedic level only does that. So suctioning, foreign materials of the airway, anything like that, we're gonna learn how to use the suction machine. Suction is a vacuum device. We have either a portable unit or we do have the mounted units in the ambulance. Each unit has the suction source, your container, your tubing, and then we've got tips, catheters, a couple of different ones we use. So the vehicle mounted or onboard suction units, suction units as a whole must generate a vacuum of no less than 300 millimeters of mercury when collecting tube is clamped, right? So that is your suction power. So here's your portable suction unit. They're oxygen or air powered, electrically powered. Most of them are electrically powered, and they're battery operated, and you just charge the battery. So even though it's portable, like I said, it does still provide that minimum 300 millimeters of mercury suction. Here's your mounted onboard suction. So just as it said earlier, we've got suction tips, catheters, the collection container, the tubing itself. Anytime everything is throwaway of all of that that's listed there. Your collection container is plastic usually. It's usually easily removable. The most popular tip or a hard tip, rigid tip suction or rigid tip is that Yankauer or the rigid tip. It has excellent device control. It's got a pretty large bore on it. It's most successful with unresponsive patients. So a lot of vomit, a lot of blood. It's pretty powerful, hard plastic device. We do have flexible catheters for suction. They come in different sizes. It's whenever we can't use that rigid tip here, that diameter of that rigid tip is pretty large. So when you have children, you need to suction nose. This soft tip is much more user-friendly. We need to be very careful when we're suctioning. This is focusing on pediatric, but as a whole, when you're suctioning, if you get into too far in the back of the throat, you're going to stimulate that vagus nerve, and it's going to slow the heart rate. Okay, it can do. And it says pediatric, but it can happen in adults as well. So the moral of the story here is that you shouldn't be suctioning any farther than you can see. All right, suctioning in. Bulb syringe suctioning is common. We've got that, just that little blue bulb for infants and small kids. We'll go over that during skills. No more than 10 seconds at a time suctioning. You place the tip where you want to suction and then close the hole and suction on the way out. Okay, we don't suction on the way in. We push the catheter in to where we get to no farther than where we can see, and we suction on the way out. If we can suction with the patient on its side, it's much better practice. It's not always possible, but it's a lot easier letting gravity kind of help you there. Suction devices can stimulate that gag reflex, stimulate vomiting. So there they are. They're positioning themselves right at the head there and being prepared to suction. So maintaining the airway, keeping that airway open. It may exceed your capabilities as a basic. Okay, if you've got some airway, you've got your patient still declining, you're going to need to get into the practice of recognizing when ALS is needed and some more advanced airway skills are needed. So if you need to call an advanced or a medic unit, we're going to be able to fully intubate that patient. And in the event of severe trauma, we actually can do a cricothyrotomy if we have to. So just be aware of that. If you're not getting that results, or if that patient looks like they're going to need to be intubated, or you've attempted all the measures you can, and you're just not getting the level of ventilation that you want, make sure that you consider that. And you might have to stop at the closest hospital, even if you're going to a different hospital, to at least stabilize the patient. It's not unheard of. So special considerations in airway management, facial injuries, that's going to cause some difficulty for us. Bleeding might require more than just once every 10 seconds suctioning. You still have to pause in between that. You might need to even take off that yank car, that hard tip, that rigid tip suction piece, and use just your tubing. So we'll go over some different scenarios during skills, discussing what to do if you have copious amounts of fluid or blood. And like it says, an ET tube or something more advanced may be needed if the facial injuries are severe. Obstructions. Your suction units are not going to be able to remove solid objects. You're going to have to go back to your basics, the Heimlich maneuver, your chest thrusts, or your finger sweeps. We will discuss using the McGill forceps if the object is far enough out that we can use the forceps to reach it. We will be going over that as EMT basics in Wisconsin. You are allowed to do that. So dentures, if dentures are in place and they are not impeding your care, then leave them alone. Okay, we're not going to try to yank out dentures. Dentures are glued in there. If they, however, have become loose and they are impeding your ability to maintain your airway, then go ahead and remove the device. Okay, otherwise, they're going to help you out. Okay? They're going to help keep your oral airway in place. They're going to help you keep those advanced airways in place. Another thing with your advanced airways and oral airways, if your patient has a gag reflex on an oral airway, you are not going to be able to use your supraglottic, your blind insertion device airways. That is not going to work. They're going to gag on those as well. So if that's the case, use your nasal airway and call for ALS, and we might have to intubate them in order to keep that airway protected. All right, so the critical thinking of the day here. On arrival at the emergency scene, you find an adult female patient. She is gurgling in the throat. You can hear it. Her breathing has slowed to almost nothing. How do you protect, and what are you going to do to proceed to protect the airway? So I want you to write down the steps that you would do to protect that airway. Okay, that's question 1. Question 2, you have a small child, you hear stridor, that high-pitched tone, that high-pitched voice when they're breathing in. What does that sound tell you? And what are your immediate concerns regarding that? All right, so that is your critical thinking question 2. The last question, critical thinking question 3. When assessing an unconscious patient, you note snoring respirations. Should you be concerned with this? And if so, what steps can you take to correct that? Okay. So I want you to take some time, answer those questions. We will go over them in class. And that takes care of chapter 9.